Hi everyone, welcome to another Monty Heart lecture. It's a great pleasure to have today Dr. Salvatore Carbone, who will be speaking about nutrition, obesity, and metabolism in heart failure, mechanistic insights, and translational opportunities. Dr. Carbone is the Associate Professor and Program Director of the Masters of Science in Nutrition program at the EVMS School of Health Professions and Associate Professor within the EVMS Division of Endocrine and Metabolic Disorders in the Department of Internal Medicine at the Macon and John Brook, Virginia Health Sciences at Old Dominion University. Prior to joining Old Dominion University in 2025, Dr. Carbone was a tenured associate professor at Virginia Commonwealth University, where he practiced for many years. A registered dietitian nutritionist and internationally recognized scientist, Dr. Carbone brings a unique blend of clinical expertise, academic leadership, and research innovation to the program and to us today. He has been named among the top 2% scientists worldwide by Stanford University in 2022, 23, 24, and 2025. And he was a recipient of the 2016 Mentor Clinical and Population Research Award from the American Heart Association and the 2019 Career Development Award also from the AHA. In addition, he also received the 2023 Investigator Award from the Heart Failure Society of America. His research, which is funded by the American Heart Association, among other agencies, focuses on dietary interventions to improve body composition, cardiorespiratory fitness, and metabolic health, particularly in individuals with obesity and heart failure. It's a real honor to have you here today with us. We're very excited for your lecture. Thank you so much.
Okay, wonderful. And thank you so much, Dr. Slipsic, for your introduction, the kind introduction, and for the invitation to be here today. So what I thought we could do for the next 45 minutes is to really discuss some of the work we've done over the last, I would say, a little over 10 years. Most of the work I'll be presenting was done at VCU, Virginia Commonwealth University, on my primary institution, before joining ODU, Old Dominion, earlier this year. But there's also some studies that I will be showing that we're starting soon here as well. And so the presentation will be divided in two parts, which are the two main focus of my research. Really, one, which is obesity, focusing on the role of obesity, and the second part, which is more focused on the role of diet. And I think one of my goal over the years was to really try to separate the effects of diet in heart failure from the effect of obesity in heart failure, which is very hard, because as you can imagine, an unhealthy diet is also often associated with obesity. And all of these aspects will be discussed in the setting of heart failure, and particularly in the setting of cardiorespiratory fitness, or CRF, which I will define in a second. And then the secondary components of the research are really a body composition, cardio function, as well as inflammation, and then finally glucose metabolism and metabolic flexibility, which is a more novel assessment of metabolic health. So starting with obesity and heart failure, I think this is, I don't need to really spend too much time to this audience for really emphasizing the importance of obesity in the risk of heart failure. These are data from the Framingham Heart Study over 20 years ago, showing that overweight and obesity are strongly associated with the greater risk for heart failure in both men and women. And then later data, these are data from Ambarish Pandey, showing that obesity is particularly a driver for heart failure with preserved ejection fraction, or HFpEF, more so than heart failure with reduced ejection fraction, HFrEF. And in fact, clinical trials really show that obesity is highly prevalent in this population. In the Paragon-HF trial, which was a randomized controlled trial in patients with HFpEF, where patients with a BMI over 40 were actually excluded, so this is an underestimate of obesity prevalence, 50% of patients were classified as having obesity per BMI criteria. However, when you use other measurements of excess adiposity, like waist to height ratio, or other studies have shown that with also waist to hip ratio, over 96% of patients have excess or central adiposity. And so nearly all your patients with HFpEF will have some degree of excess adiposity or obesity. Now, going to the cardiorespiratory fitness, what is cardiorespiratory fitness? First, there are several different definitions of it, or CRF. But generally speaking, it's really the cardiovascular, respiratory, and muscular response to exercise. And it's so important in stratifying the risk of individuals and assessing their prognosis that the AHA a few years ago really released a statement making the case for CRF to be really a clinical vital sign that should be estimated at least in all our patients. The gold standard measurement of cardiorespiratory fitness is a peak oxygen consumption in presence of a respiratory exchange ratio greater than 1 and ideally greater than 1.1. And looking at the fixed principle, peak oxygen consumption, or VO2 peak, is the product of cardiac output and arteriovenous oxygen difference, which really defines the peripheral oxygen extraction contribution to VO2 peak. And we know that in patients with HFpEF, much of the lower VO2 peak is actually attributed to a significantly lower peripheral oxygen extraction rather than an exclusive or predominant reduced cardiac output compared to what we would see in patients with heart failure with reduced ejection fraction. But VO2 peak is not a predictor for clinical outcomes only. It's also a strong measure of quality of life. In fact, in this study, this was a very elegant study published in JACC Heart Failure a few years ago. You can see here that patients with HFpEF have a dramatically reduced VO2 peak. On average, from different clinical trials, it's a 15 milliliters per kilogram per minute. And when you look at the amount of oxygen consumption that is necessary to conduct activities of daily living, like dressing or even walking at 3 miles per hour, patients with HFpEF are already above their anaerobic threshold to just complete those basic daily activities during the day. And this highlights why these patients are extremely limited in the activities that they can do, and also emphasizing the importance of identifying therapies that can increase VO2 peak so that individuals have a higher room for conducting activities of daily living. So extremely important. And so where does the obesity component fall into this? Well, almost 10 years ago, we were among the first ones to show that obesity, and particularly when you look at body mass index, was a strong independent predictor for reduced exercise capacity. But the novelty of our work was that we looked at not only at body weight, we also looked at body composition. And we'll use a device called bioelectrical impedance analysis. In this case, was a whole body BIA that we validated against DEXA. And we will talk about BIA a little bit more in a few minutes. And we found that when you looked at body composition, it's not just an excess weight that drives the reduced exercise capacity. It's the excess fat mass specifically. And importantly, in this study, we found that the fat mass index was the strongest predictor for reduced exercise capacity, even stronger than cardiac function that here we measured at rest and at peak exercise with ultrasound, as well as NT-proBNP, really suggesting that obesity is a major contributor of exercise intolerance in patients with HFpEF. And now we know also from recent clinical trials with the weight loss medications that, yes, by targeting the excess adiposity, we can actually improve functional capacity in this population. When I joined ECU, and coincidentally, you had recently one of my mentors presenting here, Dr. Abate, we looked at the effect of anti-inflammatory drugs in patients with HFpEF. And we were now looking to enroll patients with obesity. And this was a HFpEF trial, and our median BMI was 41 and 42. This is how prevalent obesity was, at least this was in downtown Richmond. And what we found is that patients with elevated fat mass index were also less likely to benefit from an anti-inflammatory drug, suggesting that really these patients not only have a reduced exercise capacity, but the excess adiposity is also limiting or preventing them from benefiting from potential treatments. But fat mass is only one component of body composition. In fact, it's important to understand, and I will spend a couple of minutes here, all the different body composition compartments. When we talked about fat mass, this is only one part of our body. The remaining part of our body is defined as fat-free mass, or FFM. But the fat-free mass is not the best surrogate for skeletal muscle mass, because this is also including bone mineral content. And so when we actually looking at body composition and we're using, for instance, DEXA, which is the reference method for body composition, we're actually measuring lean mass or lean soft tissue. And lean soft tissue is really what is considered the closest surrogate for skeletal muscle mass. So unless we're using CT or MRI, we're really unable to measure skeletal muscle mass, but we are able to estimate lean tissue and possibly, skeletal muscle mass as a surrogate. But remember that particularly in patients with heart failure, in which there could be a shift, there is a shift usually for between extra and intracellular water, lean tissue assessment can be problematic sometimes because you are not necessarily measuring the skeletal muscle mass directly. Why I want to make this distinction is that when you are looking at fat mass, you're not able to really completely phenotype your patients from a body composition standpoint. In fact, fat mass allows to define whether somebody has obesity or not, but measuring lean mass allows to define individuals who have sarcopenia, which is defined as a reduction in skeletal muscle mass, strength, and functionality, and those with sarcopenic obesity. So those are the ones who have both obesity, so excess adiposity, but also sarcopenia, so a reduction in skeletal muscle mass. And if we don't assess lean mass, we will not be able to make this diagnosis, which are critical because patients with sarcopenic obesity have a worse prognosis across a number of chronic diseases, including heart failure. And for body composition phenotyping, appendicular lean mass index, or ALMI, it's really the key body composition measurement, which essentially is the sum of lean mass of arms and legs divided by meter squared, and is used for a diagnosis of sarcopenia. So really critical to be able to have clinically available tools that could be used routinely to measure ALMI so that we can then stratify patients based on whether they have sarcopenia, sarcopenic obesity, or obesity alone. This was a schematic we worked on a few years ago, and interestingly made the cover of the European Journal of Heart Failure a few years ago. But this was just an example to really show you how limited BMI is. In fact, you can have individuals with similar BMI and really have a dramatically different body composition, particularly in those with sarcopenic obesity having high fat mass and dramatically lower lean mass. And those are the patients that we really need to pay particular attention, because those are the ones with severe impairment in cardiorespiratory fitness and worse clinical outcomes down the road. In addition to measure body composition at one time point, is also very important to track those changes over time. And I think this is particularly critical right now, especially in response to intervention that are known to influence body composition, like lifestyle intervention, but particularly now anti-obesity medication, because their weight loss is so dramatic that we need to make sure that the composition of the weight that they're losing is actually appropriate. In fact, individuals who are have severe obesity, if they lose a disproportionate amount of lean tissue, they might actually develop sarcopenic obesity and perhaps making their condition even worse. On the other hand, you might have an individual with severe obesity who are losing an appropriate amount of lean tissues and fat tissue, and those might become now having obesity, and then maybe even overweight or normal weight. But it's really important to track those body composition parameters to determine whether one individual is developing sarcopenic obesity and therefore developing tailored therapeutic strategies. So very important. And so over the years, we've been particularly interested, this is in both HFrEF and HFpEF, to really understand the role of body composition in this population, and particularly how does sarcopenia and sarcopenic obesity influence cardiorespiratory fitness. This was a paper led by Haley Billingsley, at the time was our PhD student. And what we looked at was patients with stable HFrEF, and we look at only patients with obesity, and we define obesity as a BMI greater or equal than 30. And then we divided patients into having sarcopenic obesity or obesity without sarcopenia if they had a BMI greater than 30 and an appendicular lean mass index lower than 6.75 in women and lower than 10.75 in men. And what did we find? Well, I think this was extremely eye-opening study for us, because we found that patients with sarcopenic obesity here in the white dots, they had a lower exercise capacity and the lower functional capacity measured with exercise testing, as well as cardiopulmonary exercise testing, as well as exercise time. But interestingly, these patients did not have a different amount of fat tissue. They did not have a different cardiac function that we measure at rest with the ultrasound. And in fact, those with sarcopenic obesity, despite still having a BMI higher than 30, had a lower BMI compared to those with non-sarcopenic obesity. And clinically, if we see a patient that has a BMI 31 and one with a BMI 35, we would think that the one with a BMI 35 will have a worse exercise capacity. In this case, we actually found that that was not the case. And the increased amount of the increased exercise capacity was driven by the increased amount of lean tissue that these patients without sarcopenic obesity had, which is why it's so critical to preserve lean tissue in this population, because it's really the major driver for exercise capacity. But how do we measure body composition, and how can we accurately measure ALMI, appendicular lean mass index, in the general population, or in the clinic in a routine setting? And so in patients with HFrEF, in that study I just showed you in the prior slide, we used something called segmental bioelectrical impedance analysis. This was a single frequency device, which, as opposed to older devices which only measure whole body, these ones also measured segmental body composition. So essentially appendicular lean and fat mass tissues and the related indexes. And what we found in HFrEF is that the BIA device performed very well, very nicely against DEXA without evidence of proportional biases. And then just a few weeks ago, we replicated the same findings in a much larger sample in patients with obesity and a HFpEF specifically, showing that appendicular lean mass index measured with the single frequency segmental bioelectrical impedance analysis was performed very well against DEXA, which is the reference method for body composition, without any evidence for proportional bias, and with just a small mean difference of 0.54 between the two measurements. So overall, I can conclude that segmental BIA is a valid alternative to the reference method DEXA in patients with both HFrEF and HFpEF. And this is important because BIA is a portable device. It's relatively inexpensive. Again, this specific device that we have been able to validate, it's very easy to conduct. You only need a bed, and other than that, really the technician requires very minimal training. And overall, there's no radiation as opposed to DEXA. So really a tool that can be used routinely in clinical practice and can provide very important information. BIA also allows to assess something called phase angle, which is a surrogate non-invasive measure of skeletal muscle quality, which a few years ago was shown in obesity and HFpEF to predict exercise capacity and also predict those with a lower NT-proBNP, where individuals with a higher phase angle would have a lower NT-proBNP and overall more favorable prognosis. And interestingly, we also saw that in patients with sarcopenic obesity, phase angle was also lower. So these patients not only have lower amount of lean tissue, but they also have lower skeletal muscle quality. Another assessment that you can actually perform using BIA is assessing what is called edema index, which is essentially the proportion of total body water, which is considered to be extracellular. So the amount of extracellular water compared to the total amount of water in an individual body. And we did this study in patients with HFrEF and type 2 diabetes that underwent a bioelectrical impedance analysis. And these were all patients who were considered to be euvolemic, a physical exam conducted by a cardiologist. And what we found is that first, several patients still present excess extracellular fluid, even when they're considered to be euvolemic, and perhaps they might benefit from additional diuretic therapies. And second, this excess extracellular fluid was actually an independent predictor for reduced exercise capacity measured with both VO2 peak as well as exercise time. So I think overall, I hope I convinced you or started thinking about the use of BIA to measure not only fat mass, which is historically what has been used for, but also to measure lean mass. And more recently, we can also measure appendicular lean mass, which is even more important for the diagnosis of sarcopenia. We can assess phase angle as a surrogate for skeletal muscle quality, and we can also assess edema index as a measure of the extracellular fluid. So we are currently routinely using BIA in addition to other tools, for instance, hand grip dynamometer to look also at skeletal muscle strength, as well as DEXA as well. So we continue to really look at all this body composition assessment and the skeletal muscle strength assessment to characterize our patients the best we can, as we think that really just looking at cardiac function, BMI, and even just fat alone is just not enough to stratify the risk of our patients. Now, moving to the second half of the presentation, I think, as I mentioned earlier, in addition to looking at obesity and body composition, I'm a dietitian by training. And so I've always been interested in really understanding what are the individual effects of diet and separating the effect of diet from those caused by obesity, which is very hard because most individuals with obesity will have an unhealthy diet, but you also see individuals who don't necessarily have obesity still have an unhealthy diet, and they still present a high risk for diet-related chronic diseases. And so how could we really separate the two factors? And when I joined VCU, I was very lucky to work in a tremendous lab that was composed of clinicians and basic scientists. And so we were able to do now, almost over a decade ago, some preclinical studies that really provided proof of concept to then move to clinical studies and clinical trials. And so to test the initial hypothesis that an unhealthy diet could actually affect cardiac function, we did a relatively simple experiment where we fed wild-type mice with either a Western diet, which was a high sugar, high saturated fatty acid diet, the equivalent of a McDonald's-like diet for several years in an individual. We fed mice with this diet for 8 weeks, and we look at their cardiac function as well as their body weight. And what we found first was that their body weight increased approximately, became statistically significant difference around 4 to 5 weeks from initiation of a Western diet. But more importantly, here you can see that we saw a reduction in LVEF, which was still above 50%. We did not see an increase in LV mass, but we did see an increase in isovolumetric relaxation time and myocardial performance index as measurement of diastolic function, especially IRT. But we also look at intracardiac pressure, and we saw that just the diet alone could cause an increase in 11 ventricular and diastolic pressure and an increase in interstitial myocardial fibrosis. Again, the intervention here was just unhealthy diet. And so this was to me very important because at that point we did not have the evidence, even in preclinical models, that diet alone could influence cardiac function. But also we asked the question of whether we could reverse the dysfunction caused by Western diet. And so we fed mice with the Western diet for 4 weeks. As expected, mice develop a cardiac dysfunction, and then we switched them back to a healthy, very healthy diet for mice. And we saw that within 8 weeks of intervention, the cardiac function was essentially back to baseline, really showing that there is hope, is that individuals who have had a very long history of unhealthy diet, switching to a healthier dietary pattern could possibly improve their cardiac function. And importantly, what I wanted to point out is that cardiac dysfunction appeared even before there was a significant difference in body weight, suggesting that there are some effect of diet on cardiac function that are independent of overweight or obesity. I think when we think about nutrition, a lot of us think about weight loss and caloric restriction. But I think an important question to answer is whether quality of calories make a difference or independent of whether individuals are trying to lose weight or not. And this is a critical point because first, not all individuals need to lose weight. And second, even if individuals that need to lose weight are not necessarily losing weight, but they're still improving the quality of the calories that they're eating, are we providing any benefit on hard outcomes? And so I think there are 3 studies that are really, to me, critical, and I think all of us or the work in nutrition should be familiar with. And these 3 studies are the Women's Health Initiative randomized control trial, the PREDIMET study, which was a primary prevention study, multi-center done in Spain, and then the CardioPrep study, which was also done in Spain, but as a single center study. And these 3 studies investigated the effect of dietary fats on cardiovascular endpoints. In the WHI, this was the idea at the time that a low-fat diet will reduce cardiovascular events. And everybody thought that this would be a positive study because fats were being demonized as a terrible nutrient. And so the intervention really consisted of reducing total fat and reducing saturated fatty acid. And what they found, however, was that the WHI did not show any benefit whatsoever on cardiovascular events. Later on, they did also analysis of diabetes incidence, and there was no reduction in diabetes incidence in this population, really showing that low-fat diets do not reduce cardiovascular events. To the contrary, we see the PREDIMED, a primary prevention study, where the intervention was really increasing the consumption of food like extra virgin olive oil and nuts. And in fact, there was an increased amount of calories in the intervention group compared to the control, which at the time was, again, a low-fat diet that was being recommended by most societies, including the AHA. And in the PREDIMED study, there was a reduction by a 29% relative risk reduction for the composite primary endpoint of acute MI, stroke, or death from cardiovascular causes, which was really dramatic, showing that even in absence of weight loss and caloric restriction, changes in diet quality could really affect clinical outcomes. And then more recently, the CardioPrev, which was published in The Lancet in 2022. This was a secondary prevention study, but very similar intervention. Again, there was no caloric restriction. And in fact, there was an increase by approximately 300 calories in the intervention group compared to the control. And similarly to the PREDIMED, there was a 27% of the composite cardiovascular events, which included the MI, cardiovascular death, revascularization, among others. So really the proof, I think very important evidence that nutrition, quality of diet plays a critical role in influencing clinical outcomes in this population. However, there really hasn't been any specific study done in heart failure that modulated, specifically in the heart failure population, that modulated dietary fat. In both the PREDIMED and CardioPrev, interestingly, there was an increase in extra virgin olive oil consumption. It was one of the biggest change in diet of the patients and before and after the intervention. And in particular, there was an increase in about 3 servings of extra virgin olive oil per day, which is about 30 to 40 milliliters of extra virgin olive oil, which is a large amount of olive oil in general. And so inspired by some of this work, we started looking at our patients. We look at patients with HFpEF, and we look at their dietary intake. Again, very lucky to have tremendous, terrific mentors that allow me to really financially and emotionally, I would say, some and time-wise, looking at some of the patients that were enrolled in their clinical trials. And I started looking at their diet very comprehensively using validated dietary recall systems, where we spend a lot of time really trying to figure out what our patients were actually eating. And at the end of the study, this was a cross-sectional analysis in patients. We found that patients with HFpEF consuming the larger amount of food rich in healthy fats, such as extra virgin olive oil, canola oil, nuts, avocado, and seeds as well, they had a better exercise capacity when we measured with VO2 peak, body composition, as well as cardiac function. This was really the first evidence to they really investigated diet of patients with HFpEF. At the time, we really didn't even know what these patients are usually consuming, which is very hard to then develop an intervention if we don't know what is their baseline diet. At the same time, we did a randomized trial in mice where we fed mice, again, wild-type mice, for 8 weeks with 4 different diets. One was the standard diet that I showed you earlier, which was really healthy and impossible to follow in patients. But then we had 3 high-fat diets. 2 were unhealthy high-fat diets, the Western diet and the high saturated fatty acid diet. And then the third diet here, which is a high unsaturated fatty acid diet, where unsaturated fatty acid are considered to be healthy fats. We kept the total amount of fat almost identical, but we changed the composition of the fat. And so in the high UFA diet fed mice, there was a large amount of unsaturated fat, as opposed to the other 2 high in unhealthy fat. There were no differences in calories, and so all the data, the results that you will see later, will be actually just a result of differences in diet quality, because there were no differences in quantity. And so what did we find in this mice? First of all, as you expected, the 3 high-fat diet, the Western diet, the high SFA diet, and the high UFA diet, fed mice ate more calories, and that's because those diets had more calories per gram of food. But when we looked at body weight, the mice that were fed with a high UFA diet actually did not gain as much weight as opposed to the Western diet and the high SFA fed mice, suggesting that there is something happening in those mice fed with a high UFA diet that is not making them increase their body weight like the other two high-fat diet, despite consuming the same amount of calories. And to me, what was particularly exciting is that the high UFA diet-fed mice did not develop cardiac dysfunction that we measure with ultrasound, suggesting that, again, despite the similar consumption of calories, there was not only not a gain in weight, but also there was no cardiac dysfunctions. So really exciting data, really supporting the role of healthy fat in the on cardiac function. We looked also at glucose metabolism in these mice, and we found that when you do an OGTT, so a glucose load in these mice, we found that those who were fed with a high UFA diet presented a better glucose tolerance compared to those mice who were fed with the Western diet. So really showing that the high UFA diet was also able to prevent glucose metabolism abnormalities. And this was in line with the sub-analysis of the Prediment study I showed you earlier, where patients randomized to the extra virgin olive oil group in the study actually also had a lower risk for diabetes without, again, weight loss and caloric restriction. So all this initial evidence gave us the basis for developing a clinical trial. And so this is where we're starting moving to patients. And when I was in Richmond, Virginia, the question that I really wanted to ask first, before we could look at outcomes, can patients even change the quality of the food that they're eating? And can we even increase the food rich in healthy fat in the diet of a typical individual living in downtown Richmond, Virginia? And so we asked patients to really consume one of the food listed here in this slide without any upper limit for consumption. So essentially, we asked them to consume at least 4 tablespoons of extra virgin olive oil per day, or canola oil, or unsalted or lightly salted tree nuts or peanuts. And for those who could not consume the first choice of daily consumption, they could consume some of the substitutes on the second part of the table. Our primary endpoint was feasibility. We really wanted to see whether for 12 weeks, we were able to change the diet of our patients. And what we found is that within 12 weeks of intervention, we saw a dramatic increase in reported calories from unsaturated fatty acid, monounsaturated fatty acids such as oleic acid, which is the main component of olive oil, and numerically higher, though this did not reach statistical significance, for polyunsaturated fatty acid. This is reported caloric intake, so things can be different when you actually measure objectively fatty acid in the blood. And one of the beauty of working with fatty acid is that we can actually measure them and determine whether an individual is actually consuming those food rich in healthy fat. And we were able to show a significant increase also in plasma fatty acid after our intervention to really show feasibility of this dietary intervention, at least in a single arm study. We also saw, again, very small sample of 9 patients here. We did see also some trend favoring an increase in exercise capacity, exercise time, but really we're talking about small numbers, but at least provided some evidence to support our next clinical trial. And we also saw that there are moderate to high correlations between the increases in unsaturated fatty acid and the increase in VO2 peak in this study. And so this UFA Preserve 1 study gave us the basis for designing the UFA Preserve 2 clinical trial, which was just actually accepted for publication in Circulation Heart Failure earlier this week. This was still a relatively small study, but was a randomized control crossover study. We were with the washout period phase, where we used exactly the same intervention as we did in our pilot study, except in the control group, we focus more on controlling sodium intake as a standard of care dietary intervention. Our primary endpoints were still UFA consumption reported with both diet and biomarkers. And then we were powered to test for correlation between the changes in UFA in the plasma and changes in exercise capacity. So I was very excited to actually show that we met our primary endpoints of dietary consumption. So patients, again, even in a randomized control fashion, there was an increase in the percentage of calories from unsaturated fatty acid, as well as an increase in plasma unsaturated fatty acid. But more excitingly, we also saw moderate to strong correlations, again, between the changes in plasma UFA and VO2 peak changes, really supporting the concept that if we are able to increase UFA, unsaturated fatty acid in the blood, we might be able to improve exercise capacity in this population. And so this now leading to hopefully our next study, which is going to be powered now to finally look at changes in outcomes. Another domain that we thought could be targeted by high unsaturated fatty acid diet is cardiac rehab. We know that a lot of patients undergo cardiac rehab. Cardiac rehab improves exercise capacity, improves functional capacity. However, there is still significant room for improvements, and perhaps this could be achieved by adding additional intervention. These are two studies showing on the left that even patients that undergo cardiac rehab with heart failure with reduced EF, and at the end of cardiac rehab, only less than 50% of patients achieve more than 300 meters on a 6-minute walk test, which is really not what we would like to see. And then on the right, this was data from Ochsner Heart and Vascular Institute database. They have a beautiful database that also collects exercise capacity measurement with cardiopulmonary exercise testing. And we found here that even the patients that completed cardiac rehab, unless they achieved that 17.6 milliliter per kilogram per minute of VO2 peak, their long-term survival was still quite impaired. Therefore, suggesting that at the end of cardiac rehab, there was still room for some patients who did not achieve that cutoff for VO2 peak to continue cardiac rehab, or at least having additional interventions. And so based on that, we have recently received internal funding. This is through Centera Health in Norfolk, Virginia, where we are randomizing patients with HFrEF that are referred to cardiac rehab as part of the standard of care to either an extra virgin olive oil supplementation or standard of care for 12 weeks, with our primary endpoint being changes in 6-minute walk test distance, in addition to other measurements, including body composition, skeletal muscle strength, and of course, quality of life and ultrasound, to look at other, understanding potential mechanism for improvement in this population. But one of the other questions we try to ask over the years is, what are the mechanism of diet-induced cardiac dysfunction? And I think a few weeks ago, you had much more, actually a much greater expert than myself on inflammation that really focused on the role of these NLRP3 inflammasome. And over the years, I've also done a little bit of work on that. And the idea was that an unhealthy diet might activate the NLRP3 inflammasome, which then stimulates the production of pro-inflammatory cytokine, interleukin IL-1 beta, and interleukin 18, which can then bind to their receptor and induce cardiac dysfunction. And so we did a study in mice again, where we fed mice with a high sugar, high saturated fatty acid diet. And without doing any other intervention, we found that these mice had an elevated IL-18 level in the plasma, and as well as an mRNA expression in the heart, which I think was important to show that this diet alone can cause a pro-inflammatory state. We then took mice that were knocked out for IL-18. So we took mice that did not have IL-18 in their body. And interestingly, that intervention prevented most of the cardiac dysfunction induced by Western diet, suggesting that really IL-18 is a major mediator of cardiac dysfunction induced by Western diet. However, we found something a little unusual. And in fact, mice who did not have IL-18 all over, everywhere in their body, including their brain, they tend to eat more calories, they tend to develop obesity, and despite having normal cardiac function. So there was somewhat a paradox of IL-18, and we later learned that IL-18 acts as similar to leptin and reduces food intake in the brain. And so if you remove IL-18 from completely, mice will eat a little bit more. Fortunately, clinical targets, clinical interventions like IL-18 monoclonal antibody do not cross the brain barrier, so we do not expect to see an increased food intake in patients treated with such strategy. I told you earlier that mice who were not caught for IL-18 had a preserved cardiac function, but not fully. There was still some dysfunction. And so we decided to then target not only IL-18, but IL-18 and IL-1 beta at the same time. And so we used an orally available NLRP3 inflammasome inhibitor, which is really an inhibitor of both IL-1 beta and IL-18. This was, again, a preclinical study where mice we had 4 groups. One was just a standard diet. One group was the standard diet plus the inhibitor. The blue lines were Western diet alone, and then the black lines were the Western diet with the NLRP3 inflammasome inhibitor, with the hypothesis that by adding an NLRP3 inflammasome inhibitor, we could prevent fully cardiac dysfunction in these mice. And in fact, that's exactly what we found. We saw that mice who were fed with the Western diet, but also were receiving NLRP3 inflammasome inhibitor in their diet, they had a completely preserved cardiac function despite being fed with a high sugar, high saturated fatty acid diet, and despite still gaining some weight. So we were still able to prevent cardiac dysfunction despite developing obesity. And I think now it's interesting to see that going back to the Mediterranean diet, when you think about inflammation, there was a recent statement from the ACC showing that that included for the first time a dietary intervention as a potential anti-inflammatory tool, using the Predimed as evidence to really support that nutrition alone could really act as an anti-inflammatory therapy. Another aspect of the research that I'm particularly interested in is metabolic flexibility, and essentially looking at how can diet really influence the energy substrate that individuals are using in a fasting state. When someone who's healthy does not have any type of insulin resistance, when we are resting overnight, our energetic substrate switches from carbohydrates to fatty acid. And this is what is supposed to happen here, you can see in this figure. However, individuals who have insulin resistance, they tend to have a lower ability to switch from carbohydrates to fatty acid. And this is usually assessed as a respiratory exchange ratio, or respiratory quotient, which is, again, the ratio between CO2 production and CO2 production and oxygen consumption. And we were able to do that at VCU using a $1 million hospital room, which is an indirect calorimetry room or metabolic chamber, where patients could spend overnight in the chamber, and we were able to continuously measure oxygen consumption and carbon dioxide production and really assess the energetic substrate. And what we did, this was work that I've done with Dr. Cherry, who was the division chair of endocrinology, and now is department chair at UConn, actually. And what we did is that we had patients coming to the hospital around 6 p.m., and we would give them a standardized meal, and then they would enter the room and spend 14 hours in the room, including overnight. And we measured continuously their respiratory quotient. And we found that their baseline respiratory quotient was impaired. And after providing them with a 12-week healthy fat diet, we saw a dramatic reduction in respiratory quotient, suggesting that diet alone, again, in absence of body weight changes, was able to influence energetic substrates toward a more favorable metabolic health. And this is really similar to what you would see with some of the current medications. For instance, dapagliflozin, an SGLT2 inhibitor, is shown to reduce RER, suggesting greater utilization of fatty acid. More recently, tirzepatide also is shown to reduce, to improve fat oxidation by a similar magnitude of what we've seen in our study. But again, we saw that without a dietary intervention. And we also did a glucose tolerance test, and we saw that some patients already had improvements in glucose metabolism, similar to what we saw in the preclinical study in mice that we did earlier. Another aspect of the research that we've been particularly interested in is intermittent fasting and time of eating. This was really led by Haley during her PhD. And we were really fascinated by some of the studies that were being published. However, we also saw that there were no data on heart failure. And so we started really looking at whether some of these intermittent fasting strategies could really influence outcomes in our patients. Initially, there was a lot of interest in time-restricted eating as a tool to lose weight and improve cardiometabolic parameters. However, there was this study published in New England Journal of Medicine really showing that time-restricted eating was not better than just daily caloric restriction, and perhaps suggesting that it is still a valid tool, but it's not necessarily better than what we have been doing over the years. But patients on time-restricted eating tend to have, these are post-hoc analysis from randomized trials, they reported worse sleep quality. And then in the TREAT study, they also reported lower physical activity and greater awake time overnight, suggesting that perhaps time-restricted eating might actually influence some behaviors in a negative way. And anecdotally, Haley started noticing that in our patients as well. And so we started more systematically assessing time of eating in our patients. And what we found is that in this initial study, patients who were eating their last meal later in the evening, they actually had a better exercise capacity, which was really tough to also publish this because it was going against a lot of literature that would suggest that eating earlier during the day could possibly improve clinical outcomes. We replicated that in a larger sample. We looked at midpoint of energy intake, and then more recently, this was our dissertation work. We looked at over 900 patients from an NHANES database, and we found that patients with heart failure with a larger eating window, so those who were eating for a longer period of time during the day, from their first meal to their last meal, they actually had a lower risk for all-cause mortality, as well as lower risk for cardiovascular mortality. Again, all this evidence is observational in nature and clearly requires a randomized trial, but at least this data were not really supporting the use of time-restricted eating in this heart failure population. And then finally, I'm also particularly interested in movement behaviors, sedentary behaviors, physical activity. And one of the studies that I wanted to, a couple of studies I wanted to show you is the first one. This is also data from NHANES, where we use accelerometer-based physical activity measurements. And we found that replacing sedentary time as little as 10 minutes a day with light physical activity was associated with a 7% lower risk for all-cause mortality as well as cardiovascular mortality. So dramatic benefit by switching just as little as 10 minutes of sedentary time with physical activity in patients. This was specifically heart failure. And then more recently, this was a work of my PhD student who's now just started his own lab, Imran Hamed. In our patients with HFpEF, we use accelerometer to measure physical activity, but accelerometer also allows to objectively measure sleep quality. And in this study, we found that patients with worse sleep efficiency, which essentially measures the amount of individuals that are actually sleeping while in bed, had a worse quality of life. Again, those with a lower sleep efficiency, so the one who had a worse sleep quality, had a worse quality of life that we assessed with the Kansas City Cardiomyopathy Questionnaire. And Imran, as part of his dissertation, actually did a prospective trial that is currently preparing for publication, where we've shown that as little as 2 weeks of sleep hygiene intervention can improve sleep quality in these patients. And maybe later on, we'll be able to determine whether that will result in improved outcomes. And then finally, this is my last slide. I really wanted to, as a director of a new program, I really wanted to emphasize the importance of nutrition education. EBMS and Old Dominion University recently started this program. We have our first cohort of students starting next year, next fall. But we're also working on developing programs within the medical school, because I think nutrition, which is not just preventative nutrition, is also treating medical nutrition therapy. It's also nutrition support, and enteroparental nutrition needs to be included in most of the education of our health professions, including medical school, of course. And I hope that this will be filling a gap, considering that it's a fully online, 18-month-long master's program. And so we're excited to really train the future educator and the future nutrition specialist. And with that, just wanted to thank all the collaborators and co-investigators that have allowed for all the data that I presented today to really happen and make it really obtain those results.
Thank you very much. That was an amazing lecture, and like you're saying, I think it's something that usually we're not trained as much, and it's great to have a refreshment full of also great data. So just not talking from experience, you actually went ahead and did the trial. So congratulations on your work. So for everyone, you have the CME here, and you can place your questions in the Q&A, and we'll go through as many as possible. I'll start with a question that I think is important for the obesity medications, as you mentioned. We started using these medications a lot more in cardiology for the increased cardiovascular outcomes. But as you're mentioning, we're not necessarily tracking the body composition on these patients, and in particular, older patients can start losing some muscle mass. So when you start patients in GLP-1 agonists, do you give them any particular advice about diet or exercise, or what are some practical tips that you recommend?
Yeah, so for those who are interested in this topic, there is a really nice position statement released by the Academy of Nutrition earlier this year that really focuses on dietary intervention in patients prescribed with an incretin mimetic. That goes from GLP-1 to dual agonist. Now we have amylin. We have more and more coming. But yeah, that's one of the concern is the loss of lean tissues, including skeletal muscle mass. And so first of all, we need to assess body composition. I think that's critical. And BIA really takes, I should have said, takes about 5 minutes, 3 minutes to be completed. So very easy tool that can be used to monitor changes. But it's critical now to provide education on protein intake, as well as overall energy intake, as well as fiber. Those are the three main factors, because most patients will reduce intake. This is, by definition, this is how these drugs work. However, some will reduce intake too much. And so now they will reduce it to a level that is even lower than the resting metabolic rate. That will cause dramatic loss of lean tissue, possibly. And often it really reduces the consumption of food rich in fiber. And one of the major side effects of these medications are GI. And so those are the three components that we focus on. And then protein. Protein is obviously a low protein diet could possibly contribute to lower lean mass. And so we make sure that patients are eating enough protein. Not too many proteins, because I think now there is a message in the general public that as soon as they start the GLP-1, they have to take protein powders and dietary supplements. I think that's where you need a nutrition specialist, ideally, that can assess the diet of your patient and say, this patient needs a dietary supplement. This patient does not need a protein supplement because they're already consuming enough. And I always emphasize the importance of having registered dietitian in your team to monitor that over time.
Very important. There's a lot of push now for very high levels of protein intake. So I think your comment comes very well balanced.
And I don't think there is evidence to show that anything above really 1.2 grams of protein per kilo would be beneficial. Even in critical care, now we don't go above 1.5. And these are extremely catabolic patients. So there's no need to go over 2-3 grams of protein per kilo, which many do.
Thank you very much. If you want to stop sharing the screen so people can see you better when you talk. Perfect. So we'll have a question from Rob Osfeld that leads our wellness and prevention program. He says, thank you for your terrific talk. A potential point of clarification, he says, as I recall, the Predimed study was not a study comparing dietary fat between arms, but rather comparing dietary patterns. Predimed, of course, compared Mediterranean-style dietary patterns with a controlled diet, and of note, the control arm in Predimed, as I recall, actually consume about 38% of their calories from fat, and hence control arm did not consume a low-fat diet in Predimed. Says, and as you're noting, the type of fat, like the more than total fat, is a key critical distinction. He mentions in a pre-specified post-hoc analysis of Predimed, consuming more of a plant-based dietary pattern was associated with living longer. He's interested in your thoughts regarding the impact of consuming more of a healthful, plant-forward diet on heart failure.
Yeah, that is a great question. And, for the sake of time, we didn't go into the details of Predimed, but yeah, this is true. So the Predimed was mostly a dietary pattern intervention. However, patients were being supplemented. So there was a 3-arm study. It was a control group, which was a low-fat diet, a second group, which was Mediterranean diet, and patients were receiving olive oil as part of their study, a liter of olive oil per day. And then the third arm was nuts, was a mixed nuts. I think it was almonds, hazelnut, and maybe walnuts, I wouldn't say. So it was more as part of a dietary pattern, which is true. And I should have also spent a couple of minutes in our study. We weren't just giving the food. We would also spend time and making sure that those food would be implemented as part of a relatively healthy diet. So that is important. However, when you look at the changes of diet, most of the greatest changes are in fatty acid when you look at before and after dietary recall. So those seem to be the possibly the driver of the benefit. And then to answer the question of a healthful plant-based diet on heart failure, absolutely. I think if we can increase the consumption of we can increase plant-based consumption in our patients if it's feasible and sustainable, because it's not easy to achieve in all our patients. That is, I think, would be desirable. It's not as easy, but it would be definitely desirable.
Thank you very much. We have a question from Mike Patu. He says, thank you for this talk and your important work. First question, can you comment on strength training as a way to prevent sarcopenia and as part of cardiac rehab? And the second question is if you can comment more on anti-inflammatory diets. Would you say healthy diets simply cause less inflammation, or there are foods we can promote that can actually act as anti-inflammatory agents?
Yeah, these are all great questions. So the first one, strength training as a way to prevent sarcopenia or as part of cardiac rehab, absolutely. So in HFpEF, there was a recent study called the SECRET trial from Wake Forest, where in addition to caloric restriction, they added aerobic exercise training, and then they added an arm of resistance training. The intervention was not effective in preventing lean mass loss itself, but it was effective in improving muscle strength overall. And so I think resistance training is certainly, should be, I think, recommended in addition to aerobic exercise. And lean mass alone, it's not probably enough. We should probably measure muscle strength, and you can actually index muscle strength over lean tissue, so to really have a more of an estimate of muscle quality. So it should definitely be recommended in addition to aerobic. I think aerobic still remains key, but the resistance should be added as well. And then the second question on anti-inflammatory diets. Yeah, so the Predimed, like we said earlier, was a more of a Mediterranean diet type of intervention. There are certainly basic science studies showing that unsaturated fats, like oleic acid from olive oil, have very powerful anti-inflammatory effects. Working in inflammation, we've done some work that I didn't show today, but olive oil alone can actually inhibit the activation of the NLRP3 inflammasome mechanistically. And so it reduces IL-1 beta and IL-18 production. And then there are studies from the 80s led by Charles Dinarello, who's the person who really discovered IL-1 beta, using very high dose omega-3, showing clear reduction in IL-1 beta and using CRP as a surrogate marker. So olive oil certainly possibly. I suspect that most unsaturated fats will have some degree of anti-inflammatory effect.
Thank you very much. Very good. And we have a last question from Omar Saeed, one of our heart failure specialists. He says the association between UFA and higher VO2 is interesting. If this is actually causal, which mechanisms could be playing a role? And yeah, I think it's very interesting too. We usually don't encourage patients to eat more UFA, at least myself. Maybe I should, but we focus more on the things not to eat.
Yeah, and I think this is a great question. You know, when I started working on this, especially in clinical patients, one of the challenges was how do we change the diet of our patients? And historically, nutritionists have been focused on not on things that we shouldn't eat. And so in my study, we decided to change the approach, and we said, what can you eat more of something else? And then we eventually found that patients, if they were eating more olive oil, they reduced the intake of butter, for instance. In fact, in all our studies, including the recent randomized trial, we didn't see an increase in caloric intake at the end. So patients eventually will change some of those unhealthy calories to healthy calories anyways. In terms of the mechanism, we're exploring those. One is inflammation, and so we want to see whether an anti-inflammatory effect of unsaturated fat could possibly explain some of the benefit. And the second is really the metabolic flexibility that I was showing you earlier. So if we're able to shift the metabolic substrate from glucose to fatty acids, perhaps we are essentially um, um, facilitating, or I would say we are increasing the anaerobic threshold that is required for patients during exercise. And so now they are able to basically exercise a little bit longer before they reach their anaerobic threshold and therefore improve their overall quality of life. Because I think it's the anaerobic threshold that is critical for them to be able to conduct activities of daily living. Most of our patients don't reach their peak during the day. And so if we're able to even just improve that little venture anaerobic threshold, I think we can really make dramatic changes in their quality of life.
Thank you very much. And I think I want to ask one last question that I know this is seen afterwards by many patients as well. Something they ask us all the time is about supplements, and we talked briefly about the protein powder. So I wanted your opinion on supplements, protein powders, or any omega-3 or any other supplements that you recommend in patients with heart failure.
So yeah, currently there's really no indication for any of those dietary supplements in terms of vitamins. In fact, in advanced heart failure, for those who work in heart failure, so there are some heart failure cardiologists here. There's a study called the EVITA trial published in European Heart Journal a few years ago, showing, for instance, that vitamin D was associated with higher need for MCS. So I think it's important to emphasize that vitamins are not harmless. There are potential also negative effect. Omega-3 fatty acid, possibly. There are some studies, from the early 90s, early 2000s, showing potential benefit of omega-3 fatty acid. I think we need more evidence. Proteins, really, they're not necessary unless patient is really consuming such little amount of protein, which is very uncommon in the United States. We're consuming almost double what we need. So most patients will not need dietary supplements. But again, I think should be tailored. Having a dietitian that can do that initial assessment would be very helpful. But just starting multivitamins or other supplements because they could potentially benefit, I don't think would be appropriate because there's even potential for harm. We even showed a couple of years ago, we published a meta-analysis on omega-3 fatty acid and the risk for atrial fibrillation. And so that is another concern, especially in the HFpEF population. There's already a strong substrate for AFib. Do we really want to have a risk of possibly increasing the risk of AFib if we don't know whether that intervention could really benefit that population?
Thank you very much. So there's no quick fix. We need to exercise and eat healthier, I think.
That would be great. Yeah.
Okay. Thank you very much for your time. We really enjoyed it.
Thank you. I appreciate it.
Bye-bye.